All right, so today we're talking about coagulation and bleeding. Since it is Christmas time, I figured it wouldn't be appropriate if I didn't include something about Christmas. So let me launch our pre-poll here and disregard the fact that it says joint pain. That should say coagulation and bleeding disorders. So go ahead and press the appropriate answer for you at this time. I think most of you guys are getting in there. Perfect. All right, perfect. So let me share these results here. So it looks like most of you said that you know nothing or you know a little bit. And that's perfectly okay. And what we're going to do is to see if we can't, increase that a little bit and, teach you something tonight and have a little bit of fun in the process here. All right. So let me stop that and we'll keep going here. So this is kind of our outline for tonight. We're going to talk about 3 cases in coagulation. Your guys' role, I'm going to ask you guys to read these cases. So I'm going to ask for a few volunteers to kind of read the cases out loud and participate, type in the chat or say it out loud, whatever works for you. And then the other part is filling out this SOAP note. So there's the resources that you'll need for tonight. And that will have a quiz at the end of it where you'll be able to answer that, answer the questions. There's only 10. I created the quiz. It's really simple so that you'll be able to watch this presentation, learn something, and then complete the quiz in, less than 10 minutes, I hope. That's my goal for you. It's not a hard quiz at all. It's not meant to stress you out by any means. And it should be a fairly quick process. And then, afterwards, you'll get the certificate of achievement. And often, I get asked the question, am I able to, write this in my med school application? Is it, I guess to answer that question, is it actually honored by medical schools? No, not officially, though, it is an experience that you can talk about in your med school application about how it reaffirmed your interest in medicine or why it's an important experience to you. So it's certainly not for nothing and gives you an opportunity to really, learn from home, which is always nice. Okay, so here's the SOAP note form, and this is what you're going to be filling out about one of these cases. There's 3. Choose whatever's most interesting to you. Fill out the first one if you want, and then kick back the rest of the time. But SOAP is an acronym that is for 4 distinct things. Okay, so subjective here is the HPI and the ROS. So HPI is the thing that the patient tells us, and this is kind of the narrative of the patient. Review of systems is the pertinent positives and negatives. Okay, so if somebody's coming in with dizziness, we might ask, do they have nausea and vomiting? Have they had headaches? Things like that are pertinent to the chief complaint. All right. Objective is the things that we find. So things like the vital signs and the physical exam findings. Assessment is essentially our differential diagnosis. So things that we think are going on. And then our plan is what we're going to do based on that differential. All right. So this should be fairly simple. If all the information is not there and you know a little bit, or you've learned stuff about the, the patient and this pathology, add it into, your SOAP note and use it as an opportunity to practice your documentation for the future. So this is, basically designed to have you practice these things in kind of advance of medical school in your future training. All right, so wherever you guys are at, go ahead and mark it. So if you go up to your toolbar, you can go to annotate and then click your stamp. You guys should be getting good at this by now, I suspect. Go ahead and mark where you're at. Oh, we have lots of Texas this time. Lots of stars. Oh, there's someone also in Florida. The Floridian, where are you at? Ah, Panama City. Awesome. Cool. I'm in Pensacola, so I'm right in your neck of the woods. I did a rotation in Panama City, actually. Cool. So we have lots of people from Texas. We have a South Carolina. We have Tennessee, all over the place. California. We have a Utah even. We have Canada. Lots of people. We have East Coasters. You guys are dedicated, staying up. It's 9 o'clock your time. So perfect. Let me clear this. Regardless of where you guys are at, thanks for coming. Thanks for bearing with my initial issues with my internet. Seems to be an uphill battle, but let's get started. The first thing that we're going to talk about is hemostasis. Okay, so when we talk about hemostasis, what we talk about is this idea of vascular injury happening that's going to cause physiological clotting as a result of injury. Okay, so this is essentially, if we were to number this, we'd say, okay, vascular injury happens, that's number one. As a result of that, these two factors, tissue factor and collagen, activate systems in the body in order to repair the damage, in order to have this idea of hemostasis. So basically, tissue factor activates the coagulation cascade, while collagen activates platelets. Okay, and we're going to learn this idea. Platelet activation is primarily primary hemostasis. All right, while the coagulation cascade and all the factors involved, that's secondary hemostasis. Okay, so that's kind of the first thing. But in addition to that, so these two things are happening, but when we get vascular injury, the artery often clamps down. Okay, so if you've ever seen somebody try to put in, an arterial line or anything along those lines, what you'll see often is the actual vasculature reacting to it. And that is a physiological mechanism in place in order to protect the body, to prevent fluid loss, to prevent, blood volume loss. Okay, so it's kind of an innate thing. And then, we're definitely going to talk about the coagulation cascade, a little bit about von Willebrand factor and fibrinogen causing this platelet plug. But we know that thrombin, which is factor 2, is a cofactor to form fibrinogen, which goes to fibrin, which cross links to cause a blood clot. And that's what we want to do. That's our goal. That's our end product, is causing a fibrin clot that prevents bleeding out, essentially. That's our big thing. Okay, so here's primary hemostasis, as we kind of indicated, and then secondary hemostasis. So seems simple for now. And if you guys have questions, just throw them out there. All right, so we're doing a little bit of a kind of a background before we get into some of the cases. All right. So here's the next thing. Okay, when we talk about primary hemostasis specifically, there's a lot of things that kind of go on with it. A few things that I want to kind of point out is this idea of platelet adhesion. So we get this, vasoconstriction, as we kind of talked about in the last slide. And what we see is that, the collagen being released from the vascular endothelium causes platelet activation. Okay, so what we see is platelets kind of go to the site, kind of adhere based on the the different adhesion molecules that platelets actually have on them. They change their state, their shape, and release different molecules like ADP and thromboxane A2. Okay, and a lot of those cause recruitment of other platelets and other things like aggregation of the platelets. And then what we see down here is secondary hemostasis, where we see tissue factor released, and then the coagulation cascade kind of starts after that. So in terms of pathology associated with you know, primary hemostasis, we're talking about things associated with platelets. Okay, keep that in mind. When I say primary, you say platelets. Okay, so that's what I want you to think of as a little bit of foreshadowing. That is 100% a question that you're going to see on that quiz in a few minutes when you do that. Okay, so primary hemostasis has to do with things with platelets. Okay, so thrombocytopenia, low platelets, Glanzmann's thrombasthenia, and Bernard-Soulier. These are problems with different molecules on the platelet. Okay, and we have ITP, immune thrombocytopenic purpura, and then we have thrombotic thrombocytopenic purpura. Kind of turns into like an alphabet soup. And then kidney disease can also lead to problems with the platelets due to uremia, due to increased nitrogen, essentially. Okay, so here's a little picture down on the bottom right-hand corner. When we talk about Bernard-Soulier, we see a deficiency in this glycoprotein 1B, which leads to a lack of adhesion of the platelets. So it can cause bleeding as a result. And then Glanzmann is this other glycoprotein 2B3A. That's less important for you to know. I'm not going to ask you about that. But that's just to kind of know where these things kind of come from. The more important thing for you to realize at your level is this idea that if there's primary hemostasis, it has to do with the platelets, and there's kind of a mechanism involved for the platelets to adhere, change shape, and then, you know, recruit additional platelets. All right, so let's talk a little bit about secondary hemostasis here. And there's a whole thing that kind of goes on here. You know, one thing that's always important to remember is vitamin K dependent factors. And we know that things like warfarin it's basically a vitamin K, that was a horrible R. Warf, I'm going to put Warf because I'm too lazy to write the whole thing out. It's actually really hard on the mouse. But anyway, so vitamin K dependent factors are 2, 7, 9, and 10. I heard, you know, one of my classmates say, you know, I remember it because 2 plus 7 is 9, and then you just remember 10. For me, none of those tricks often don't work for me. I just remember 2, 7, 9, and 10. Those are vitamin K dependent factors. Those are the things that depend on vitamin K to be produced by the liver. All right. Now, the other thing that we're going to talk about is these two arms of the coagulation cascade. So that's what we're looking at over here, this thing that's probably making you go cross-eyed already. We'll first start with let's start with the extrinsic pathway. When we talk about the extrinsic pathway, the test that tests for the extrinsic pathway function is the PT. Okay, you may have heard of that. What we usually use is the INR, this international ratio that kind of standardizes our PT test. Okay, so what happens is we get trauma, and factor 7 is correspondingly goes to activated factor 7. Okay, tissue factor is a cofactor here, which kind of and then activated factor 7 is a cofactor to factor 10. And you'll see that there's factor 10 kind of coming in at this side, and that comes as a result of the intrinsic pathway that kind of starts over here because of endothelial damage. And what we see for the intrinsic pathway is, you know, the APTT is the test to manage that. And then, you know, as we kind of see here, one factor is the, you know, cofactor to the other. So factor 12A, the activated one, that's what A stands for, is the cofactor for factor 11. And then we go 12, 11, and then 9. Doesn't make a lot of sense, does it? We know that the coagulation cascade kind of coalesces with factor 10A. But less important that you remember all of this different stuff. At one point in your career, you might have to remember this. But the more important thing that we see is this idea of the coagulation cascade kind of coalescing to this common pathway. That's what we call it here, the common pathway. where fibrinogen, factor 1, uses thrombin to turn into fibrin. Remember, that's what we want here. This is our end product, the cross-linked fibrin clot, okay? And then that's what it's talking about here, this kind of common pathway, usually factors 10, 5, 2, and 1. Those are the common. Okay, so here's the test, the PT, PTT, and then we're looking kind of at that fibrin cross-link clot. And we'll revisit this again at the end when we kind of talk a little bit more about some of these pathologies and kind of put it into context, okay? I know that this is a busy slide, lots to see with the coagulation cascade, but hopefully we can make this make a little more sense in the slides to come. Okay, so here it is again, and we talk about the coagulation cascade a little bit more here in terms of secondary hemostasis. Things like hemophilia A, B, and C. Hemophilia C being a deficiency of factor 10. Hemophilia B being a deficiency of factor 9, and then hemophilia A being a deficiency of factor 8. Okay, so here's the kind of secondary hemostasis disorders. There's vitamin K deficiency that can cause a problem as well. Liver disease, large volume transfusion can cause it to kind of dilute out the factors. And then there's coagulopathies as well. All right. And here's various ones. If we have a deficiency of factor 5 Leiden, that causes a hypercoagulable state, as well as protein CNS, because that causes breakdown of the actual clot. All right, and then there's a few other ones that are genetic, like antithrombin 3 deficiency and prothrombin. Those are a little bit rare, so they're not covered as extensively, just really universally. All right, so let's keep going so we can kind of get onto our cases. One last thing before that is this idea of Virchow's triad, which is these three things, which sets up this, perfect storm, if you will, of, endothelial injury, hypercoagulable state, and venous stasis. All right, so if we see these things, we call this Virchow's triad in terms of these things are what leads to clotting. We get injury to the endothelium. We have something that causes a hypercoagulable state, whether that's pregnancy, a genetic disorder, a long car ride, a long airplane ride, and then venous stasis. If the blood is not moving as much, it sets it up for coagulation. Okay, and then here we kind of talk about a couple of mixed disorders, meaning it's both primary and secondary. All right. Okay. So here is the first case. If we could have somebody volunteer to read here, I would appreciate that. It's a fairly simple case, I think.
A 30-year YOF presents with an extreme fatigue and aphasia. The patient's spouse is present and notes that she has been sleeping most of the day for the past 3 days, as well as has some unusual bruising. ROS is also positive for fever, but no NVD. Past medical history is positive for SLE, for which she takes I'm not sure if I can pronounce this.
Yeah, no problem. It's hydrochloroquine.
Hydrochloroquine, okay.
Good. Awesome. So thank you for reading first. Next of all, a few things that I want to clarify. This is nausea, vomiting, and diarrhea. This is lupus, systemic lupus erythematosus. And then what else can I clarify? You guys know ROS, review of systems. Hydroxychloroquine is a drug used to treat lupus. But what I want you guys to do is pull out your markers and kind of point out the things that may be pertinent to this case. Good. So somebody kind of pointed out the extreme fatigue and aphasia. Good. That is essentially what is the chief complaint. Sleeping most of the day. Good. So it really shows kind of that fatigue. Unusual bruising. Good. I would say that too. I think that that's important. Fever. Okay. Good. And she has lupus. Good. So I think you guys are on point. What tests do you guys want to order? Go ahead and let me know. What do you think is going to kind of point you in the direction of, you know, what you may think is going on? CBC, good. Yeah, we want to look at white blood cells. Good. For those of you that said CBC, what do you want to look for specifically in someone that has fatigue and is bruising? Platelets, sure. Hemoglobin, good, Harley. I agree with that. I think if you look at the hemoglobin, we can see this patient is anemic and having bruising as a result. Good. We can look at PT, PTT. I agree. Excellent. My question for you now is, what differential diagnosis are you considering at this point before I give you, you know, physical exam findings and labs? Anemia, good. Certainly, especially with fatigue. When you have fatigue, you know, pallor, bruising. Yeah, good, Alejandra. Absolutely, we want to consider something like cancer, sure. Especially if someone has weight loss too. Our patient doesn't have that necessarily, but we can't rule it out at this point, so good. Anything else? What are you guys thinking? So we see bruising, okay. So it could be something to do with weakness and fatigue, sure. What else? And in the meantime, I'm going to give you this. This is the physical exam finding that we saw on the patient's skin. This is something that we kind of call petechiae, so little kind of pinpoint bruising essentially. And when it kind of coalesces into a spot, we call that purpura, but we don't see that here. We just see petechiae. All right. Any additional differential diagnoses that we want to throw in there? So kidney disease indicator. I will give you a lab that is going to point you in the right direction, Adam. Could patient symptoms be associated with lupus? Could be. Good. Yeah, we could be kind of an acute on chronic manifestation of lupus. Yeah, absolutely. Anybody else? Any ideas? Let me give you some more information here. Alzheimer. I mean, in a 30-year-old might be, you know, might be a stretch. Check muscle tone. Yeah, certainly, for sure. It could be, you know, definitely a problem with, you know, dermatomyositis, polymyositis, stuff like that. ALS even. All right, so here's the white blood cell count for all my friends that said, let's check the white blood cells. Here is the hemoglobin. What is this? High, low, normal? Low, good, excellent. And then here's our platelets. High, low, normal. What do you think? Yeah, it's low. Good, good. So normal is like 150 to 400 is around normal ish. 150 to probably 300. So what we see is an anemia and a thrombocytopenia. All right, so let's get more information. We know a little bit about what's going on, but I don't think we can just say this patient has anemia and thrombocytopenia, right? There might be more to it. So let's get some additional tests. Here's the blood slide down in the bottom right-hand corner. As you guys may or may not know, some of the cells kind of have this this biconcave appearance to them naturally. All right, so what we're seeing here is, you know, what is called reticulocytosis. So we see a few kind of immature cells, and as a result, we see some spherocytes. Oops. And we are seeing, you know, also, you know, immature cells. We're seeing basophilic stippling, in kind of in anisocytosis, different sized cells. So we know something is going on here. We don't have normal red blood cells. Then here on the left, we see somebody asked for a PTT. There's your PTT, it was normal. And then we see the creatinine is high. So what is your differential diagnosis now, based a little bit about what you know? And my question for you now, is this a problem with primary or secondary hemostasis? Tell me that much, and then we'll talk about the diagnosis, because this will be hard for you guys to pinpoint. Excellent. Yes, Matthew and Alejandra, quick to the, Sammy, you guys are quick to the punch there. You're absolutely right. And Megan, good. This is a problem with primary hemostasis. Why? Somebody give me a reason why you've kind of ruled out secondary hemostasis here. So the platelet's low, but what tells you it's not secondary? You could have a low platelet and it's still being, yeah, good, Josh, excellent. Yeah, because we could have a low platelet count and it still be a problem with secondary coagulation. We have a normal PTT in the setting of, what looks like maybe a problem with renal failure. We don't have a GFR here, but we do have a high creatinine. So let's talk about this diagnosis a little bit. So good job. I think you guys picked up the pertinent things here. And this is a case in a pathology called thrombotic thrombocytopenic purpura. If you want to sound fancy, you can say that at your Christmas parties coming up and impress everybody. You'll sound smart. Or if you don't want to say it because it's complicated, just say TTP. Everybody will know what you're talking about, and that's fine. So the etiology of this is a deficiency of this this protein Adams TS13. And basically what this is essentially like a pair of scissors that cuts von Willebrand factor. And what we see is here's, there's a little cartoon over there to the right. We see Adams TS13 kind of cuts von Willebrand factor, which leads to normal von Willebrand factor adhering to, platelets. Whereas when we don't have Adams TS13, we see platelets aggregating in these kind of microthrombi and correspondingly thrombocytopenia, because these guys are all kind of aggregating here because we don't have that scissors there to kind of cut that von Willebrand factor. So the long aggregates or the long von Willebrand factor causes aggregation of the platelets. So what causes this? Sometimes, it can be an inherited cause. Sometimes we may not know, but things that may cause it are things like cancer. Our friend lupus or enemy lupus, our patient had that, if you remember. Infections, different medications, things like mitomycin C, which is used as a chemotherapy agent for things like esophageal cancer, cyclosporin, which is an immunosuppressant. We give that sometimes whenever we're trying to suppress the immune system when we're doing transplants, for instance. Quinine, not really used anymore. Quinine is actually found in tonic water. Helps with restless leg syndrome. That's what it was given for a billion years ago. And then these other things that are platelet that inhibit platelet aggregation. And then yes, we can have this inherited cause. But how do we diagnose this? We look at the labs and the history. So there's no kind of one test that says, oh, we have a deficiency of Adams TS13. It's really just this, clinical diagnosis. All right. So that's the first one. I know it was a tough case, but I do think that you guys, so von Willebrand factor, essentially it's a factor that is on platelets to allow aggregation of platelets. And if we go back, I think one of the cartoons a few slides ago, let's go back and see if we can't look at it here, because pictures are good. It might have it on here, and of course it doesn't. But so here are the, maybe it has it on this other one. Let's see. Oh, it's right here on the, if you look at the image B, von Willebrand factor is a factor that allows platelets to adhere to the endothelium and adhere to each other and in different molecules. So it's a mechanism to adhere, basically. That's what VW is. It's von Willebrand. It's fancy. It sounds German. I don't know if anybody's German and they can attest to that, but seems like it. And we, abbreviated VW. Okay. All right, so let's keep going here. That's our first case, and we're off to case 2. So let's have somebody new. What is the treatment for TTP? Usually TTP is, it transfuse platelets if we need. The other thing is it can be treated. Usually it's treating the underlying cause, and then also we can transfuse platelets. Sometimes if it's due to something else, we can treat with steroids, but there's not a lot to do with it, admittedly. Okay. All right, so let's keep going. So somebody read our next case, please.
A 16-year-old female presents with a 2-day history of gradually worsening bilateral leg pain. The pain is located mostly in the calf, does not radiate, and is not associated with an injury. No recent travel or illness. Past medical history is unremarkable, and she is not on any medications. She notes that her father died from a clot in the lungs.
Okay. Perfect. So, what other kind of questions do we want to ask this patient? Anything or other tests that we want to order? D-dimer, yeah, good idea, Harley, certainly. We can order an x-ray, especially if this patient has leg pain. That's certainly something we can consider. Good. Does it happen when she's more active and gets better at rest? Good. Yeah, that might kind of pinpoint us to some of these other causes like likely not in a 16-year-old like osteoarthritis like we talked about last week, or rheumatoid arthritis. Good. Excellent. And what tests do you guys want to order other than x-ray? What do we say? D-dimer, certainly. Ultrasound, good. Yes. What are you guys looking for with the ultrasound? You always have to have a reason for why you're ordering stuff. A clot in the lower extremities. Good. Yeah, that's what we want to rule out. Or DVT. Exactly. Good. Yeah, you guys are on point there. Also, Matthew, I just remembered when we transfuse for TTP, usually fresh frozen plasma. I don't know why it just popped in my brain, but that is the treatment for TTP. Anyway, we want to rule out a DVT, certainly. And so that's obviously on our differential diagnosis. What else do we want to include on our differential diagnosis? Ideas? What do you guys think? Yeah, we can consider PE. And so what questions would we want to ask if we want to get a further history, or we want to get pertinent positives or negatives for a PE? Chest pain, good. Yeah, what else? There's a specific type of chest pain too. I don't expect you to know that. It's called pleuritic chest pain. So chest pain when you take a deep breath. They might also see what? So they're climbing stairs and they're like, oh, I can't do this anymore. Not because my leg hurts, but because of what? Shortness of breath. Good, Josh. Excellent. You guys are a very smart group. So here's the physical exam findings. We had a positive Homan sign here, and this little cartoon, this little Netter cartoon shows you this. We have a positive Hohmann sign, which is when you extend the knee. So this is knee extension, obviously, it's extended. And then we dorsiflex. So when the foot is down towards the floor, like you're stepping on a plant, it's plantar flexion. And then when the foot goes upwards as such, that's dorsiflexion. So what we're doing is we're dorsiflexing the foot and extending the knee, and we get pain in the calf muscles. This is usually indicative of a DVT. So good job for those of you that thought we might be on that path. So what test are we ordering then? What is the way we confirm what we think is going on? If you had to pick one test, and I said, your grade depends on it. If you guys actually got graded here, what would you say? What test in terms of imaging or lab test? Sorry, that was a very non-specific question. I might have misled you there. So we have one vote for MRI. What else do you guys think? Ultrasound. Yeah, good job, Madeline. Yeah, good job, Megan. Excellent. So the test that we're ordering is usually yeah, good job, Matthew. I was just about to say a Doppler ultrasound of the lower extremity. And what we're looking for is this. We see here's a normal, or, you know, here's the vein when we're not compressing. And here's when we compress with the ultrasound probe on the vein. And what we see is that the vein looks the same when we're compressing and when we're not. That means the vein is not actually compressing. So we have lack of compressibility. That's a problem. And that is indicative of a DVT also. Okay, so my question for you now, we kind of narrowed it in on what may be going on here. We don't know why, and that's what we need to figure out for a patient who has an unprovoked DVT, meaning there's not anything that set her up for this. She's not on birth control pills. She didn't travel in a car from you know, New York to LA, you know, in one sitting, you know, nothing like that. What part of the history points us in the direction of what may have caused this DVT? Yeah, good. Dad died of a blood clot in the lungs. Yeah, so and that tells us something that might be going on in that regard. Okay, so now primary or secondary hemostasis? Are we talking platelets or are we talking coagulation factors here? Good. Yeah, excellent. Everybody's kind of saying secondary here. I think you guys are all right. And let's talk about what actually is going on with this patient. So we have a patient, only 16 years old, unprovoked, has a blood clot. Dad had a PE, it sounds like, and died from it. We also had a positive D dimer. There you go. I put that in last as anticlimactic. But what we're talking about here is something called factor V Leiden. And we're going to talk a little bit about it, which the etiology behind it is a mutant factor V, okay? And this is because of a point mutation. I know you guys, like, your ears all perked up because you know what that is, which is great. So all that stuff you learn in undergraduate doesn't necessarily go away completely. And what we see is a point mutation, which is a guanine for adenine substitution, which leads to this, you know, mutation here, where we get a whole amino acid switch. So point mutation. Okay. And what that results in is this mutant factor V, which is resistant to protein C degradation. So we'll go back. I'll point this out when we get to the coagulation cascade again. But protein C, helps to break down factor V. So if we have a factor V that is mutant and is not recognizable by protein C, it won't get degraded or degraded at all. So that's a problem. That causes clotting. Okay, so that causes a hypercoagulable state. So this is a genetic thing, as you guys kind of talked about. This can lead to things like recurrent pregnancy loss, DVTs, which our patient had, and things like stroke. So we diagnose this by genetic testing, and we can do it an activated protein C resistance assay, which tells us we have that mutant factor V, and we may have an elevated PTT as a result, so that intrinsic pathway, okay? How do we treat this? We anticoagulate. We prevent the patient from becoming hypercoagulable, prevent those complications, those increased risk of clotting, okay? And then over here, we kind of have this normal physiology here where we get activated protein C, which degrades factor V, and we get the breakdown of that clot. And then here, what we see is if we don't have that, that activated, or we have a mutant factor V Leiden, we don't get that degradation, basically, is what that's showing. A simple way of saying that, okay? So let's keep going here. We have one more case to go through. It looks like we're doing decent on time. All right, let's get one more person to read.
I can read. A 27-year-old female presents for labor following a normal pregnancy. Labor progressed normally, though she suffered a postpartum hemorrhage 2-2 to uterine atony. The bleeding was stopped with uterine massage, though she is now experiencing bleeding from her IV lines.
Perfect. Thank you for reading. Sorry, my dogs decided to also help you read, I guess. Let's see here. So we're talking about pregnancy now. We're talking about this woman of whom had a normal pregnancy. Now she's bleeding and having a postpartum hemorrhage due to uterine atony. We're going to talk about uterine atony in a second. This is something that I talked about long ago in April. We'll go over those slides as well, so you get kind of a little bit in OBGYN as well. The treatment for uterine atony, and basically what uterine atony is you have this uterus that's kind of puffed up. There's a baby in it at one point, and now it's not contracting back down to normal size. And if it's not contracting back down, it's not clamping down those uterine vessels, and it's bleeding, which is a problem. And the treatment for that is uterine massage. You give it a little shiatsu, and it actually does go back down. Usually that is the treatment for it, okay? But what the problem is now is, yes, we treated that, but we're getting bleeding from her IV lines, bad. So what questions do we ask? And more important, if this patient is bleeding from her IV lines, what tests are we ordering? Is she on blood thinners? We can certainly ask her that, absolutely. CBC, yeah, let's look for platelets. You can also look at our hemoglobin as well. It's always monitored, especially in someone of whom had a postpartum hemorrhage, to see if they're anemic and see if we need to transfuse this patient. Okay, anything else? What else do we want to order for this patient? Totally off topic, still be able to breastfeed? Yes, they can, because usually the uterine atony doesn't have a lot to do with the breastfeeding in terms of hormones or anything like that. Because usually hormones, what we see is prolactin causes the proliferation of the ducts of the breast. And then oxytocin causes that contraction of which lets milk let down. That all is a mechanism between your hypothalamus to your pituitary to the target organ, which is the breast. So it shouldn't affect it at all. Though, that's all to say, it shouldn't affect it, but if a patient has a postpartum hemorrhage, and correspondingly has something that we call Sheehan syndrome, an infarction of the pituitary gland, we may see a problem where we're not releasing hormones that should be released from the pituitary. Okay, so what that manifests is as women who can't breastfeed, women who never have a period again, or other problems in terms of low thyroid, things that are released from the pituitary. So that's a great question. In terms of if we're able to correct it and the patient doesn't have an infarction of her pituitary gland, yes, but if she does, then no. Okay. Anything else? What other tests do we want to order? So here's our patient. Oh yeah, good, Josh. PT, PTT, absolutely. Let's look at those. Here's our patient. We're seeing some bleeding, and sort of, what would be, yes, some petechiae, some purpura, but some frank bleeding from the patient here. Ultrasound. What are we ultrasounding, Bridget? Any ideas? And here's our labs. Somebody said they wanted a CBC. Good idea. This patient has a hemoglobin of 7.1. At what point do we transfuse? Do you guys remember from our anemia talk, from all those other talks? Do you remember the cutoff for transfusion? That's okay if you guys don't. It's 7.0 is our cutoff. If this, it is a cutoff, but if we have a patient of whom it has frank bleeding, just had a postpartum hemorrhage, is this value realistic? Maybe, maybe not. Could be lower. Ultrasound to check for blood clots. Good. Yeah, we could have, systemic, consumption coagulopathy here. Good. And then we see a low platelet. Our PTT and PT are prolonged. There's your PT, PTT, Josh. We have a D dimer that's elevated. What does D dimer show us? So D-dimer, if you guys are not sure, D-dimer shows us that there is a clot in the body, but does not tell us where. Okay, so in that regard, is this test sensitive or specific? Tell me that much. So if it tells us there is a clot, yeah, good, exactly. If it tells us there is a clot, and we can be sure that if the test is negative, there's likely not a clot going on in the body. That makes a sensitive test. If it doesn't tell us where, that means it's not specific, okay? And then we see a fibrinogen of which is decreased, okay? Let's see if we have any other labs here. Okay, here is our blood slide here. So we see some schistocytes, and that is our friends here, kind of these, another word for those is fragment cells. So we see them here. So we know that there's something going on here. Now, my question for you guys is this a primary or is this a secondary cause of hemostasis? Primary, secondary problem? So good. Sammy, I think is on the right track here. It can be both here. This is kind of a trick question in that the platelet's low, the PTT is prolonged, fibrinogen, which is a factor of the coagulation cascade. So basically what this is saying is that this and this are the same. This points us in the direction of secondary, a low platelet and mucosal bleeding from IV lines that can tell us primary. So that kind of points us in the direction of this. In the kind of context of an obstetric emergency or trauma, that points us into something that we call DIC, disseminated intravascular coagulation, is a primary and secondary cause of bleeding. And you know, basically a consumption coagulopathy. And what happens here is we get clotting factor, which leads, you know, as a result of pro-inflammatory cytokines. We kind of see this here. This example gives us sepsis. Ours is more trauma, you know, bleeding. It's an obstetric emergency, which leads to the release of tissue factor from the white blood cells. This causes, you know, fibrin deposition, causes increased clots, and causes you know, clots and microvascular consumption of these clotting factors. And that's what we're seeing here. We're seeing activation and consumption of them, which leads to bleeding, and that's bad. You know, causes of this, sepsis, oddly, snake venom can cause it, and snake venom can also cause pancreatitis. It's a rare cause of pancreatitis and truly DIC as well. But a lot of times we see it in trauma, we see it in obstetric complications, and we can see it post-transfusion as well. So there are a few causes of it. We diagnose this through elevated bleeding time, where, you know, an old school kind of barbaric ways, like you would cut a patient and like wait until they like stopped clotting. We have different technology for that nowadays. And then the PTT is elevated, tells us that both the extrinsic and intrinsic pathways are impaired. We have a problem going on with the actual factors in the clotting cascade. We see decreased platelets because they're being consumed into these microthrombi. We see anemia and thrombocytopenia. So we see low red blood cells, and then we see low platelets. Okay. So what's the treatment of this? Treat the underlying cause. We can give fresh frozen plasma. And what this is essentially replacing clotting factors, okay? And then when we give things like red blood cells and platelets, this obviously replaces red blood cells and platelets, okay? So it corrects the anemia and the thrombocytopenia. You know, if we talk about cryoprecipitate, we're talking about a difference in adding fibrinogen as well. With this patient that's low in fibrinogen, this might be a consideration as well. All right, so let's go back because we have a couple seconds here, and let's talk about uterine atony so that we have a little bit of context to this. So basically, uterine atony, this is the exact slide that I presented from in April, is a problem when you get the distension of the uterus because of or after pregnancy, because the uterus is not contracting down. There's a cartoon down here. You can see the engorged blood vessels of the uterus wall, and when it's, you know, expanded out like that, you're getting a problem where it's not clamped back down to vasoconstrict those arteries. So we're getting bleeding after pregnancy. So what causes this? We can have it as a result of multiple gestation. So, you know, if the mother has multiple pregnancies, if there is twins, big babies, so we say greater than 4,500 grams, polyhydramnios, so lots of amniotic fluid. Also, when we see the myometrium of the actual uterus being kind of exhausted, if it's a long labor, or if we use oxytocin for a prolonged period of time. And then the other causes is of actual uterine atony is things like we can get postpartum hemorrhage from things like from laceration, so or things like tissue. So if we get the placenta kind of adhering to an abnormal part of the or if you get the placenta kind of attaching to over the Oz, then we can see bleeding as a result of that. We're primarily talking about this. These are just other extra causes of postpartum hemorrhage. Other things as, as a result of thrombin, which is hypercoagulable states. And then the next slide here, how do we, determine that we have a postpartum hemorrhage? Basically, it's greater than 500 milliliters on a vaginal delivery or 1,000 on a C-section. And what do we see when we see postpartum hemorrhage? We can see DIC, so that's highlighted here. This is the same slide that I used before. Other things, we can see a laceration, we can see missing tissue, we can see lethargy, altered mental status, we can see a soft boggy uterus, which is that atony that we talked about. We can use, various labs to diagnose, often H&H, so we're looking at the hemoglobin and hematocrit. And then we really want to type and cross to see what the patient's blood type is and cross match to make sure there's no antibodies, so we can transfuse this patient and raise their hemoglobin. All right. All right, so that was a little bit about atony. Here's obviously our disseminated intravascular coagulation. And then here's my last slide for you. And this is basically the same slide that I had before. But here's what I was talking about before when we talk about activated protein C. It goes over here to inhibit factor 8 and factor 5. So remember, if we have that mutant factor 5 here, it's not able to be inhibited by protein C, which inhibits those to prevent clotting. Okay, so if we can't prevent clotting, we have increased clotting. All right. And then here is kind of this breakdown of different causes of bleeding, based on, the platelet count. We can talk about, if the platelet count is abnormal, okay, what's going on, and pinpointing what's going on with the platelets specifically, whether it's the mean platelet volume over here, or we do a platelet aggregation assay to kind of pinpoint what exactly is going on, whether it's, von Willebrand's disease, Glanzmann's, a problem with different receptors, or all these other different causes. But as you see over here, if the PT and PTT are prolonged, then we might want to, do a mixing study where we mix the patient's serum with normal serum and see if there's a problem due to a missing factor, so a factor deficiency like hemophilia. Okay, so this is a little outline just so you get kind of this big picture overview of bleeding disorders. There's lots to it. You guys kind of got a little bit of a taste today. But let me clear this. And what I want to do now is not take too much of your time up, but I want to relaunch this poll so that you guys can answer kind of where you're at now, about an hour, into this. All right, perfect. I think most of you are in there now. Let me share these results with you. Very humbled. I think nobody said they know nothing, which is always nice, always a relief. I think most of you said you know a little, and and most of you said 69% of you said you know some. So it's been a pleasure. That is my last slide. There's my my sources there. And what's next now, you guys can certainly finish that quiz. It should be fairly easy for you. If you run into any problems, just let me know. I'd be happy to address them. Here's the link again for the quiz and the SOAP note and everything if you missed it. Feel free to log off if you're ready to go. If you have any questions about the presentation or medical school or anything, I'll stick around for a few minutes so that you guys can ask those. But otherwise, it's been a pleasure. I love doing this. Is one of my favorite things of the week. And I hope you guys will be with us next week. I think I'm teaching again next week, and hopefully I'll have a better internet connection by then. But if you guys have any questions, I'll stick around for a few minutes and answer any of those. form that you're going to figure or fill out. Okay. So the subjective is kind of what the patient tells you. So these are all subjective findings. It's what the patient tells us. Okay. Objective is things that we find. So vital signs, physical exam findings. For some of these mini cases, I didn't give you exactly everything for it. Something you can do is for the pathology, if you know what might be going on, or you can look it up yourself, do a little bit of research and say, okay, if a patient had DIC, what vital signs would they have? Okay, they would have maybe a normal temperature, they might be tachycardic, they might have low blood pressure because they're bleeding. So kind of filling in those gaps to kind of force you to think a little bit. And then the assessment is what we think is going on. So a patient that's bleeding and is after an obstetric complication, we might say postpartum hemorrhage, or we might say anemia, and we might say DIC, things like that. Kind of fill in our differential diagnosis, our assessment, and what we think is going on. And then plan is how we're going to fix that. So for DIC, we treat the underlying cause. So we correct the anemia, we give factors, we give platelets, we give blood to kind of to rectify that. Okay, so this is the SOAP note. Fairly simple. If you don't have all the answers to fill it out, that's definitely okay. It's more for your practice. All right. For all three cases, no. So choose one and just fill it out to the best of your ability with one case. Okay. Yeah, I wouldn't make you do it for all three. That's cruel and unusual punishment.
I had a quick question.
Yeah, absolutely.
So I was trying to get my brain to wrap around some of this stuff. This was not my favorite thing in school either, but I guess I need to learn it. So if protein C breaks down factor 5, but if you have a deficiency of protein C, then that means factor 5 level is increasing, which causes what again? I'm sorry.
Yeah, so it sounds like your question is primarily surrounding protein C, activated protein C and S deficiency. Is that right?
Yes.
Okay, cool. Yeah. So all this stuff, a lot of it is kind of based around if you know normal, abnormal. Okay. So what is going on in here is, we see protein S is a cofactor to get to activated protein C. So you'll see that sometimes written as APC. Okay. So what you see is protein C combines with thrombomodulin, another factor less famous than the other ones in the coagulation cascade, but those combine together to create a complex called activated protein C. So say, here's protein C, we'll call thrombomodulin the square. Together, those kind of make activated protein C. Protein S is a cofactor, okay? With activated protein C, what it does is it goes to inhibit factors 5 and factors 8. So we see if you inhibit an inhibitor, you essentially have activation. Okay, that's all that is. So we don't have that thing that stops the coagulation cascade. Basically, we can call this the brakes. So if we don't have any brakes on the coagulation cascade, what we see is it keeps going. And we get clots where it may not necessarily be warranted. So it's basically like if you took a truck on the top of the hill, cut the brake line and pushed it down, it's going to keep going. Okay. Whereas, normally if we put the truck on the top of the hill and we have this thing where we have protein C, thrombomodulin, and activated protein C, we know that we can, slow down the clotting. Okay. So when we have protein C deficiency, we don't have that, what's going to break this down. Similarly, with factor 5 Leiden, we have a mutant C, or a mutant factor 5 rather. So, instead of this, we'll say this red factor 5, what we have is a mutant version of it, which is, maybe this pink factor 5, which is close but different because we have that point mutation in the point mutation in it. So basically protein C doesn't recognize it. It doesn't know to go and stop this one. All it knows how to do is inhibit this protein or this factor 5. It doesn't know how to inhibit this one. So therefore we get increased, coagulation as well. Okay, does that answer your question, hopefully?
Yes, it did. Thank you.
Yes, absolutely.